G'day everyone. Today we're starting the first part in a two-part brief review of hypertensive emergencies. We'll cover a definition, treatment goals, and some notable exceptions to those treatment goals. So what is it? Two things define a hypertensive emergency. The first is a blood pressure of greater than or equal to 180 on 120, and the second is evidence of acute end organ damage. Now, this can manifest in a number of ways. Neurologically, we can see focal signs, altered mental status, visual disturbances, and seizures. Cardiovascularly, we can see the chest pain of acute coronary syndrome or aortic dissection, or dyspnea secondary to acute pulmonary edema. Investigations will show pathology in the systems listed above and in other systems, things such as an abnormal ECG and chest X-ray, elevated troponin and creatinine, and an abnormal CT brain. Once we've identified it, we should do something about it. Textbooks will tell us to lower the SBP by 10 to 20% in the first hour and no more than 15% over the rest of the day. We don't want to lower the BP too quickly because we could cause ischemia in vascular beds that have become accustomed to higher pressures. In case you left your calculator at home, you can just aim to get the SBP down to 180 in the first hour and then 160 after this. Hypertensive emergencies are often categorized by the target organ being damaged, and within these categories, there are exceptions to the goals we've just discussed. Let's mention three of them. In patients with acute ischemic stroke who are candidates for thrombolysis, we want their SBP to be less than 185 on 110 prior to thrombolysing them. In ischemic stroke patients who are not candidates for thrombolysis, a BP of up to 220 on 120 is tolerated. Teaching is that acutely elevated blood pressure in this circumstance is necessary to maintain perfusion to borderline ischemic areas. It's worth mentioning that blood pressure targets in hemorrhagic stroke are a different ballgame altogether. In aortic dissection, we want the SBP to be brought down to 100 to 120 as soon as possible to lower the shear stress on the aorta. To achieve this, we also want the heart rate to be about 60. And the last exception we'll talk about today is sympathetic crashing acute pulmonary edema. In this situation, we're happy to bring down the SBP to 140 pretty quickly. So that's part one of hypertensive emergencies. Next time, we'll talk about how you might go about achieving these goals. Thanks for watching.